Hello, Dr. Spiritos. It's so wonderful to have you on the episode today. I'm super excited to chat with you and discuss. We have many different topics on the agenda, and I wish we had honestly hours to talk more today because you are a wealth of knowledge and yeah, just so excited because a lot of my listeners are not familiar with what your profession is, or even that there's a gastroenterologist out there that focuses on what you do. So, if you could just describe a little bit more about what it is that you do and kind of why you got here.
Yeah, one, thank you so much for inviting me. I'm really excited to be here and giving me this platform to chat with you. So, I am a neurogastroenterologist. I trained at Duke University for my fellowship. Um, so, kind of at a 100-foot view, the difference between a traditional gastroenterologist and a neurogastroenterologist is that I tend to deal with more software issues as opposed to hardware issues, which the traditional gastroenterologist deals with. So, the latter of which is Crohn's disease, ulcerative colitis, peptic ulcer disease, where there is a objective finding on endoscopy or imaging. In neurogastroenterology, we kind of live on this axis between the brain and the gut. So traditionally, we take care of conditions like irritable bowel syndrome, motility issues like gastroparesis, slow transit. We also work with those who have pelvic floor dysfunction. And then there's esophageal issues like achalasia, where the esophagus doesn't empty very well. And then in taking care of a lot of folks with motility disorders, a natural progression was taking care of those who have underlying dysautonomia. So dysautonomia are those folks who have issues with their autonomic nervous system, or just not working properly. And what that means is that uh, well, the autonomic nervous system really has it kind of helps the GI. It really coordinates the GI system and also the cardiovascular system as well. So these folks often have postural orthostatic tachycardia syndrome. So not only deal with their GI symptoms, but also take care of the cardiovascular and neurologic uh, issues that these folks deal with. I also treat mast cell activation syndrome. So it's kind of a wide variety of complex chronic invisible conditions that people struggle with, not only touching on their GI health and helping people poop regularly again, but be in less pain, sleep better, eat better, try to get people less stressed, and then also deal with the cardiovascular implications of POTS.
Mm. I know that a lot of people that are listening to this right now are probably thinking, where have you been all my life? Because their experiences with traditional gastroenterologists are usually, you go in, you do your colonoscopy, your endoscopy, whatever it is, your main complaint is usually treated with some sort of diagnostic test, and they might even rule out that everything looks fine, and then they might be given something like a low FODMAP diet, or okay, everything looks great, it's all in your head, or an antidepressant, right? So I know that for me personally was very much my experience. It was antidepressant, take a laxative, be on your way, which is obviously very frustrating as a patient to go through that experience. And so what you've done here is you've really married this holistic approach with the conventional gastroenterologist, and wonderful that you are here today and just educating people and sharing more, especially when it comes to the POTS and dysautonomia, mast cell activation. I know when we were talking off air, I mentioned, I've been doing this in my practice for many years. And as I've kind of gotten deeper into more complex cases, especially cases like SIBO, I've been starting to see a lot of MCAS, even EDS patients, mast cell activation, seeing this a lot post COVID. So, here we are in this very, intricate web of, information. So hopefully we can break it down for the listeners today and just share some insights in what you do and, how you help these clients and patients and, guide them towards finding better care for what they're dealing with.
Absolutely. Yeah, getting a diagnosis is certainly the trickiest thing because a lot of folks will come to me with a diagnosis of irritable bowel syndrome,
Mhm.
and I do more undiagnosing of IBS than I do diagnosing IBS. And IBS is very real. There's a lot of people that struggle with IBS, and I think it becomes pejorative saying that you have IBS because I get it. It is not a well described syndrome, and it is a syndrome. Like we're not quite sure why it happens. We do believe there's some dysfunction between the brain gut axis, So we call it a disorder of the brain interaction, or a DGBI. And we think like in that, like it's caused by kind of neuroinflammation, dysbiosis, where the microbiome perhaps isn't as healthy as it used to be, but that's as precise as it gets. And so we love precision medicine, where if you take an analogy like urinary tract infection, you get the urinalysis, you get the bug that's causing that infection, and then you say, okay, well, this bug we know respond to X, Y, and Z antibiotic. IBS is kind of far from precision medicine. It's more of art over science. So it's, pattern recognition, and then also making sure they don't have anything else going on, because IBS can be, there's a lot of conditions that kind of masquerade as IBS or IBS type symptoms. So that's step one, is getting to that point of obtaining a diagnosis, because it can be challenging, because yeah, there's a lot of things that mimic IBS, and oftentimes it could be tricky to tease through, but a careful interview is where we first start.
Yeah, and you mentioned like the importance of having enough time with your clients is something that's very important to you, which I know is really difficult to do in a conventional medicine setting, right? When you are only given so much time with clients. And so taking that holistic approach is sounds like a big part of your practice.
Yeah, I mean that's key, because if you don't spend time, like this is a it'd be nice if I said, okay, you have these symptoms, I'm going to run these 3 blood tests, it's going to tell us exactly what's going on.
Yeah.
Doesn't quite work like that in neurogastroenterology. So a lot of it is, when did this start?
Hmm.
um, how is this affecting your life? What makes it better? What makes it worse? Careful diet history, careful exercise history, careful sleep history, why people don't sleep, family history. And there's so much antibiotic use in their childhood. Were they born vaginal delivery or cesarean? So all of these data points are meaningful, because the objective data sometimes isn't the most helpful, and sometimes it
Hmm.
is, but usually we are collecting a variety of different data points that kind of lead us via like breadcrumbs in a certain direction. And interview
Hmm.
plays a big role into kind of how we interpret data as well. So you marry the subjective information and the objective information, and all of that takes time. And so if you
Hmm.
try to cram that into 20 minutes, you're just not doing you're just not going to get to the bottom of it. You're just going to continue to test and test and test and throw things at the wall. I'm hoping
Hmm.
that it sticks, but it really just requires diligent history taking, curiosity to keep pursuing answers when perhaps the first, second step, doesn't work. Uh,
Hmm.
yeah, so it takes time, and an intimate knowledge of kind of how the GI system works, and
Hmm.
how you know uh, how motility works and how it's felt and sensed. And so that these all are tools that I use to kind of get people on the right track.
Amazing. Very well said. What are some of the most common digestive symptoms that you see in patients with POTS, EDS, MCAS? We could walk through like maybe one by one. And if there even are, like, are there some very obvious symptoms, maybe even not just GI related, that a patient comes into your practice and like a light bulb kind of goes off where you're thinking, okay, that's MCAS or
Yeah, early on I made myself the IBS guy pretty quickly in my clinic. I love talking about sleep and stress and exercise, and I touch on all these issues when we can and have enough time to do so. And then, slowly but surely over the last couple of years, have these patients who have like cramping and bloating and reflux. And then they're also like, my heart races and I have brain fog. And I get these random weird rashes and I have pain with sex. And you're like, huh, like this
mm,
doesn't make sense. Like, why does this 23-year-old see 7 different subspecialists? Why do they see a neurologist and a cardiologist? Like, perhaps there's something deeper here. And this was probably my first year by myself, or second year by myself, where I was like, this isn't making a whole lot of sense. And so, just kind of seeing more and more, you realize that there's something like mast cell activation syndrome that connects all of these seemingly disparate symptoms, where a patient sees their primary care doctor and like, look, doc, I feel terrible. I have debilitating migraines. I can't sleep. I'm anxious. A heart race is like, and your PCP typically will say something along the lines of, okay, I got an answer for you. You're going to see a cardiologist, and then a neurologist, and then a GI doctor. And you're like, goodness. And then when you see all these subspecialists, like nobody's connecting the dots. And so that's where, so to bring it back to the original question, it's like, so when do you kind of think something like MCAS is going on? And it's when there's multiple systems involved.
Mm-hmm.
And so if someone has digestive issues, but they also, you know, brain fog, palpitations, kind of wheezing, nausea, reflux. Reflux is a big one as well. And I talk to people about this all the time, that everybody with reflux, everybody's reflux has a story and it has to make
Mm-hmm.
sense. And the reason why reflux happens is incompetence of this valve between our esophagus and our stomach called the lower esophageal sphincter. So where kind of food and acid and liquid can come up into our esophagus, causing heartburn, causing regurgitation. But there has to be a reason why that lower esophageal sphincter is incompetent. So it usually happens in someone who is carrying a lot of abdominal adiposity, um, and has an elevated BMI, just because it puts a lot of pressure on that LES and can distort it, or someone who has a hiatal hernia, and where the LES just isn't working as well anymore because the hiatal hernia disrupts how it works. That said, I saw dozens of young, healthy people with rip roaring reflux disease, and they're put on PPIs. This doesn't make any sense. There's no reason for you to have reflux disease, and it ends up being MCAS a lot of the time, and or something else like eosinophilic esophagitis that can behave this way. But when the narrative doesn't make sense, if you just can't, if people just don't get reflux, there has to be a reason for it. It doesn't just happen
Mm-hmm.
out of the blue. So if the narrative doesn't make sense for GI conditions, or perhaps there's multiple systems involved, then I start thinking of something like mast cell activation syndrome.
Mm-hmm.
And then once you start probing further and you say, okay, does your heart race? Do you get dizzy when you stand up? They're like, oh yeah, that happens too. I thought that was just normal. Like, that is not normal at all. Um, and you'd be amazed what people just kind of deal with because they're told it's anxiety or stress. Like, you're fine. You just need to take some deep breaths. Which, goodness, like, that's a whole conversation in and of itself, that why that's problematic. But
Mm-hmm.
yeah, that's generally when my light bulbs go off, when it doesn't make sense why someone feels the way that they do.
Mm-hmm. Yeah. And from a dietary perspective, I see clients, they'll come and they're like, I don't eat tomato, I don't eat chocolate, I don't eat this. But so they've cut out all these like, typical reflux foods and they're still feeling the reflux symptoms. And a lot of people don't even know that they have reflux, which could be something that you could elaborate on a little bit more as the conversation around silent reflux, the thing that I used to do all the time that I remember my friend, one of my best friends, she would make fun of me all the time. It would kind of be like the running joke that I would always be like doing this throat clearing thing. And then, of course, went down the rabbit hole of like reflux. But a lot of people don't even realize that they have reflux. They have this like chronic postnasal drip and, the kind of like clearing the throat. And I did a post on this, and so many people were in the comments like, it's Tourette's syndrome. Yes, that's definitely possible, but it's also very common that I see in my practice that it is actually silent reflux. Do you see that a lot in your practice?
Yeah, I mean, I get referred patients with quote unquote extraesophageal symptoms attributed to reflux all the time. So, reflux, as like the cardinal symptoms, are heartburn and regurgitation. And again, I want to go back to the fact that everybody's reflux has to make sense. It
Hmm.
doesn't just happen. Like, why are they getting reflux disease? And there has to be a reason there before we can convincingly say this could possibly be reflux. But I do have people all the time who have chronic throat clearing, laryngeal symptoms, like their voice has changed, a chronic cough. And so 20 years ago, we would just say, oh, start a PPI and see what happens. And that's no longer done because, one, it's imprecise. And you can sometimes just, if you take that logic, people will just be on a PPI in perpetuity. And then that's not great either. And so we do have testing that we could, if we are suspicious that people have extraesophageal symptoms of reflux disease, there is testing that we can run as well.
Hmm.
But I'm hesitant to do so unless someone really has a story for it. So if you're a young, thin person and
Hmm.
don't have a hiatal hernia, like, I don't think this is reflux disease. Like, I have to prove it to myself
Hmm.
that it's reflux disease, and I'll go down the MCAS route first. Or do you have something like eosinophilic esophagitis, something like that could cause, I guess that doesn't actually cause extraesophageal symptoms, but um, yeah, it's yeah. So there are reflex tests that we can run where we kind of use a probe down the nose called an impedance catheter that people wear for 24 hours. It's as lovely as it sounds, and it records kind of if acid or air kind of comes up into your esophagus throughout it over a 24-hour period. That could then at the same time, people can record symptoms when that happens. So if they're throat
Mm.
clearing a lot or coughing a lot, and we see that, oh my goodness, at the same time that you throat cleared, you are having either acidic or non-acidic reflux coming back up, then we can
Mm.
kind of make that diagnosis.
That's super interesting. It does sound very uncomfortable, but at the same time, very important and very informative.
Yeah, absolutely.
That's excellent.
But yeah, no, I've encouraged. I read a lot of my impedance studies in my group, and just maybe 2 days ago, I got there's a patient who has she's young. She maybe has a BMI of 26, and she's being considered for anti-reflux surgery. And she has a history of diffuse allergies and migraines and pelvic pain and endometriosis. And I messaged the surgeon and the GI doctor. I was like, look, she definitely has reflux on this study for sure. But like, I think we should think about mast cell activation syndrome. And
Yeah.
there's a lot of crickets because not a lot of people know about MCAS. We weren't taught about it in medical school. To
Hmm.
what you alluded to before, it kind of exploded with COVID. Um,
Hmm.
and so yeah, and you just have to think outside the box when the narrative isn't quite making sense.
Hmm. What, like, I'm trying to think of a way to ask this that isn't so loaded, but general like direction with a patient that comes to you with MCAS. I mean, what are your next steps that you're going to do with them?
Yeah, I think I want to break this into one or two parts because one of my intentions with the social media Instagram account is I don't want to gatekeep any of this. So I will bet that most physicians that you see in traditional healthcare will not be aware of what are not aware of what MCAS are. And if they
Hmm.
do know, they don't know how to diagnose it and they don't know how to treat it.
Hmm.
So what I tell people out there that if they have a lot of these mystery symptoms, bloating, diarrhea, cramping, brain fog, palpitations, and you read online people's narratives about their history with MCAS or other experts who describe MCAS. You're like, you know what, that kind of makes sense for me. And I met my doctor, and I got met with kind of a lot of just referrals to subspecialists or just generally like I'm not sure where to go with this or how to put this all together. The first line for MCAS is is over the counter therapies that work quite well.
Hmm.
In fact, the diagnosis of MCAS, which we can get into in a second if you'd like to, is quite it's tough to make that diagnosis, but one of the three criteria for making the diagnosis is response to therapy.
Hmm.
Therapy is a combination of an H1 and an H2 blocker.
Hmm.
So the H1 blockers are traditionally used for allergies, and these receptors are located in the pulmonary system, the upper airway system, and I believe there's receptors in the brain as well. And we use medications like Zyrtec or Allegra,
Hmm.
coupled with H2 blockers like famotidine or Pepcid. And these receptors are located in the GI tract, the cardiovascular system in the brain as well. And so we use a combination of these medications, and they usually work quite well. I had a patient maybe last week who had, goodness, she just moved from California. She probably had like two colonoscopies, a video capsule study, an upper endoscopy. And I was like, this sounds a lot like MCAS because she had the whole litany of, extra GI symptoms. And we put her on Pepcid and Zyrtec, and she's like, I feel great. Like everything is gone. Maybe she had a little bloating after she eats some leftovers, which we can get into kind of the histamine diet and everything like that. But I was like, it's amazing, right? And so you can do this at home if you'd like. And certainly that's the tip of the iceberg. And that's the ground floor of MCAS therapy,
Hmm.
the H1 and H2 blockers. And sometimes we have to layer on other therapies as well, like mast cell stabilizers. And that can get quite nuanced depending on who you are, what symptoms you have. So I don't want to paint with a broad brush and say like just try it all, but you can start with an H1 and H2 blocker. And we started a fairly high dose, Pepcid 40 milligrams twice a day. I do Zyrtec 20 twice a day. If Zyrtec tends to make you sleepy, I use Allegra 180 in the morning and Zyrtec 20 at nighttime. But the weird thing about MCAS is that people just respond to the excipients or the additives to a lot of these medications. So they try one, but they can't tolerate it. So we have to try another one. So say, okay, well, there's another wrinkle to this. If you can't tolerate the Pepcid, you can go to a different H2 blocker. And similarly to Zyrtec and Allegra, and sometimes you just have to rotate it. And I'll
Hmm.
start therapy for like 2 to 3 weeks at a time and say, how do you feel? And like, I want to know all of your symptoms, like really rank them and say, how much better are we in each of these categories? And if we're doing well, perfect. And then we'll get into diet and see if we can get you off these medications long term. But it's more of a proof of concept starting therapies like that.
Hmm.
There are tests that work okay. I don't recall the sensitivity of it. It's not incredibly high, which really just means that out of 100 people, I imagine these tests probably pick up 60 to 70%, which is not like an incredibly accurate test, but it's generally a 24-hour urine collection to try to identify some of these mediators of mast cells. The mast cells themselves secrete over 1,300 chemical compounds. So we're trying to pick up on a few of them, but it's really tough to detect them. And so there's three tests we use, generally speaking, and there's a serum tryptase as well, which is a blood test, which is far less accurate than the other ones, but it can be helpful if you're for other reasons. So that's my general approach. If I have a hunch for it, because quite frankly, there's not a lot else that causes these symptoms. There just isn't.
Hmm.
And
Yeah.
so when you put it all together, you're like, what else is on your what's called a differential diagnosis? What else could be causing this? Unless you say someone simultaneously has endometriosis, migraines, um, an arrhythmia, and IBS at the same time, there's nothing linking those two. It's statistically very unlikely. So I just kind of go for it and put
Hmm.
people on therapy. But I have a lot of touch points with my patients. So I say in 2 weeks, let me know how it's going, and then we can
Hmm.
layer other therapies because this is an iterative process, and it does take time,
Yeah.
and it can be a frustrating experience. But once we get there, people are like, "Goodness, like I saw the light again." Like,
Yeah.
one, I'm just thankful that I understand what's going on with my body. And
Hmm.
two, that they can go out to dinner. They can work through a full day without having debilitating brain fog. Their heart isn't pounding out of their chest when they stand up,
Hmm.
um, and that's a little POTS therapy as well that we don't necessarily have to get into. But it's complex, but it's a lot of fun because you help these people really connect the dots when they, quite frankly, their body was a mystery to them for the last 20, 30 years.
Yeah. Yeah. I mean, kind of your equivalent to the antihistamine treatment is like an antihistamine diet or low histamine diet. And I'll give you a case study. Recently, a patient came to me with, severe PMS symptoms, like very, very anxious, like debilitating anxiety, painful periods, heavy periods. And even just 2 weeks, I said, in your luteal phase, try a low histamine diet and then just see what happens. And she was like you said, night and day, night and day. And again, that's not where we stop, right? It's just the confirmation of this is clearly histamine at play.
Yeah.
And what a wonderful thing, like you said, to be able to, at least you make that connection, then you move forward from there. The question that I had for you was that urinalysis that you mentioned and the tryptase test. Is this something, or both of those things, that you would want someone to do if they're in a flare, or does it not matter at all?
The tryptase means more if you're in a flare.
Okay.
But and the other three are fairly sensitive, independent of the flare, so to speak. And what I most, if not all of my MCAS patients, they're never not in a flare. Like, look, it gets worse, but there's always like day to day symptoms and just
Okay.
feeling crummy. And
Hmm.
so, and I get it's part of the diagnosis, but it is not the diagnosis.
Hmm.
So
Okay.
even if the mediators are negative, and I have a high suspicion for MCAS, I'll just put people on therapy, which is what I do for the most part. Not because I want you on therapy in perpetuity, but it's a proof of concept. Because if you get better with Zyrtec and Pepcid, and a lot of these symptoms clear up, like goodness, it's got to be this, even if the mediators are negative. And so
Hmm.
I use the chemical mediators. It's a 24 urine collection. It's a leukotriene E4, there's a prostaglandin D2, and there's an N-methylhistamine are the main tests that I use.
Hmm.
And yeah, and even conferring with the experts out there who they've been doing MCAS for a decade and are really were part of this kind of the grassroots MCAS movement when not a lot of people knew about it. They perform similarly, where they just say we just put people in therapy because it's quite well tolerated. And then once you establish the diagnosis, then you work on, okay, how do we do this for the next couple of decades? How do we make your life as tolerable as where you can do the things that you want to do, and on the most minimal medications possible. And as you said, we talk about the low histamine diet as well, which can be challenging, right? And that takes a lot of coaching, especially with the leftovers and how to deal with cooking and freezing and reheating from a frozen perspective. And like that takes a lot of you have to adapt. And what happens if you're a nurse and you're in the hospital all day? Like, goodness, how do you even operate? And so I think there's a balance there. And so the medications give you a little bit of breathing room when the
Hmm.
diet is either really challenging to do or maybe isn't sufficient, because mast cell activation syndrome is more than just the histamine diet. The histamine diet
Right.
decreased the histamine load, but a
Mhm.
lot of the symptoms are driven not only by the histamine that's secreted by the mast cells, but the other over 1,000 chemical mediators that it secretes.
Mhm.
Um,
So essentially what you're saying is you're kind of just you're pouring less fuel into the fire, but you're not actually treating the root cause.
yeah, yeah. And then the question is do they have histamine tolerance or is it MCAS? And that's something important to decipher as well, because the former is mainly diet mediated. So you eat something as a high histamine load, and
Mhm.
then you feel bloated, flushed, heart racing. MCAS is more, these mast cells are kind of pissed off by anything and everything, like the way
Mhm.
you feel, pressure changes, temperature changes, medications, food. And so it's a lot more unpredictable and seemingly unstable. So histamine intolerance has a lot more cause and effect between eating high histamine foods. And in that situation, a low histamine diet is definitely the way to go. And histamine blockers do help. That's
Mhm.
definitely where I drill into diet. The MCAS, it's tricky because I definitely will. The low histamine diet, it, especially from the leftover perspective, I find can be challenging. And I'd love to hear any tips that you have, because maybe I can. I'd love to learn from you here. Um, but it is, to your point, it is kind of part of the puzzle, and it's
Mhm.
tough to create a restrictive diet for those who. Some people don't find it restrictive, but for those who do find it restrictive, it's tough to put a lot of eggs in that basket when perhaps that's not actually going to do a ton.
Mhm.
But it's worth
Yeah.
exploring, certainly, if someone wants to decrease the medications they take on a day-to-day basis.
Yeah. Yeah, I mean, it's a struggle. And even a client I met with this morning, she has EDS, dysautonomia, POTS. And so histamine foods are a big challenge for her. And she also just doesn't like to cook, which is really tough, right? If you have issues with histamine, most of the foods should be fresh, not leftovers. And ideally, we want to reduce ultra processed foods regardless, but leaning on those foods in general also aren't ideal if you're dealing with all these complex health issues. So we utilize the freezer a lot. When the second she makes something, her mom's also been really helping her with preparation. Immediately throws stuff in the freezer so that she can pull it out, put it in the air fryer. Those are just a few tips. She, has tried, getting more into the kitchen and just getting more comfortable with making some of these foods. But everybody's journey is so different. And then I also see clients that also have SIBO, and so I always remind them that it's not a no histamine diet, right? It's a low histamine. So we're trying to just also create a healthy relationship with food with a lot of these patients who have maybe now have a really negative relationship with food because of their history and health issues. And so, it's not the goal is not no histamine, right? Because it's really, really not a good quality of life, especially if you're going to have to maintain this diet for a longer period of time, but limiting the amounts from food in addition to eradicating things like bacterial overgrowth or histamine producing bacteria that can also be creating excess symptoms. And then even just as simple as if a client is constipated, as like that's going to create a lot worse issues in terms of their histamine and estrogen clearance and just quality of life, right? Bowel movements are, we all know, we feel better when we have regular bowel movements. So very, very complex. Agreed for the same topics.
Yeah, and I do. I think you made a great point. Customizing the diet to the person and meeting them where they are, and not just taking like
Hmm.
a low histamine diet and say, hey, you have to eliminate all these things. You kind of, I think it's important to comb over someone's diet to say, hey, where can we make changes here? And they're like, you can't touch my tuna fish salad. Like, I just love tuna fish. Like, all right, well, we can't do that then, right?
Yeah.
And then maybe we use some medications or a DAO enzyme. I don't know if you
Yeah.
incorporate that into your practice as well.
Hmm.
So I think there's a lot of, the important thing is that there's no, the beauty of these conditions is that you can get creative, and you just, you know you got to understand, what a not only the patient's diagnosis, but what they care about and what makes them
Hmm.
happy, because that should all be peppered into the treatment. Because if you just
Yeah.
say, all right, blanket, here's all the high histamine foods, don't eat that, like, you're not going to make a friend out. Like,
Right.
you're going to get, that's
Yeah.
not the right way to go.
And I've had clients who, they're that like they're at that point in their journey where they're like on a very strict low histamine diet. And I'm almost like encouraging them to just loosen it up a little bit because it's then creating more stress for them. They're not attending social events. Like it gets to a point where it's, we have tools, like you mentioned, the DO enzyme or, working on stress management, which might be a big part of their, health picture. We don't want to see it as the only tool. And I think that that's really important. So I'm not saying I encourage them to like liberalize their entire diet, but it's not that a complete avoidance of all histamine foods is nutritionally sound, but also, mentally good for you as well. And that we know the gut brain connection is very much connected to, let's just say everything, right? Everything related to our health, especially GI issues.
Yeah, the anxiety around eating is tricky. It's very
Hmm.
tricky. And I'm
Yeah.
sure I'm sure you deal with RFID a lot, and that's where I use
Hmm.
my GI dietitians. I work with them very closely to help certainly with untangle a lot of the stress and anxiety around eating. Because
Hmm.
if you don't know what's going on with your body, you just eat something, you feel miserable, like I can't eat that anymore. But like in certainly in histamine intolerance, that link can be there, but in other conditions like irritable bowel syndrome, perhaps what you ate in that moment or the most recent thing that you ate isn't what's causing you pain right now. In fact, it's something that you ate 8 to 10 hours ago. Or
Yes.
perhaps it's something kind of psychological as well, like your
Mhm.
goodness, your job, your boss just called, or
Mhm.
it's tax season, whatever. And so you start eliminating all these foods because it makes sense, right? Like, I just ate this, I feel bloated and I'm cramping. And
Mhm.
so naturally you start crossing off all these foods that perhaps otherwise are actually okay for you, but it's just
Mhm.
complex. And that's why working with someone who kind of has a intimate understanding of pathophysiology and motility and diet really
Mhm.
would behooves people to tease out what's real and what's not.
Yeah. I mean, I spoke with a client this morning who kind of similar thing. It was, I ate this, I had this reaction, and therefore it was what I had just eaten. And it was like, okay, well, let's talk about Friday. What happened Friday? Oh, I had two drinks. And okay, what happened Saturday? I also had two alcoholic drinks. And I also ate cheese, which I don't usually eat. I just reintroduced it. And okay, so was it truly this that you just ate, or was it, your gut was already in a stress system because you just had a few drinks this weekend? And so, yes, I mean, I personally struggled with really horrible ARFID when I was dealing with my digestive issues. I had a list of maybe like five foods that I could eat. And I've talked about this a lot in terms of like food sensitivity testing. I did one of those food sensitivity tests and it gave me, a host of foods that I quote unquote shouldn't eat because they were inflammatory and triggering to me. And it only further worsened that. So some of my favorite work to do is helping these types of patients rebuild a healthy relationship with food. And I do incorporate some food logging in my practice, but I usually do it in picture form. Well, I'll have them snap a picture of the food, and I encourage them to focus way more on like the stress around the meals, the, other lifestyle symptoms. Were they constipated for 3 days before they ate that food? So I think that's a really underrated part of all of this, in terms of GI. And as you know, you work closely with these dietitians, but yeah, I mean, it's carrying a lot of weight for the individuals who are struggling with it. And I can sympathize with that because I've been there and I know how horrible it is, but I have a wonderful relationship with food now and I feel very grateful for that. So I like to encourage others to pursue that part of their journey, no matter where they're at, GI wise.
Yeah, I mean it's amazing that you bring that unique experience to the job as well, because you have your expertise in nutrition, but also, you're able to empathize certainly more and
Mhm.
then give an inside peek into like what it's like to have RFID and how you got back
Yeah.
to kind of having a healthier relationship with food. I think is a very important perspective to have.
I dug up my food sensitivity card this past week and I was going through some old files and I was like chuckling to myself. I found my gastroenterologist list. It said low FODMAP. That was my prescription. And then my food sensitivity test. And I was like, oh, what a time. Um,
Yeah, it's tricky. And that's, you have to work with someone to understand your diagnosis or what's going on, because
right.
then that will direct why you should eliminate certain things and
Hmm.
why certain things trigger you. And perhaps it wasn't the cheeseburger that you ate, although maybe it was a cheeseburger that you ate. That's a bad example, but maybe it's, your mother-in-law called. Not, I love my mother-in-law. That wasn't, but other people may not. I probably shouldn't have said that. But you know what I mean? Like it's just, I think it's important to
Right.
work with someone who understands what's going on in your body, so then we can then focus our efforts towards the right diet and the right approach. Because
Mm-hmm.
when you're,
Absolutely.
yeah, randomly crossing things off the list, it's just, yeah, it's a tough game to play.
Sure. Can we dive in? I know I've gotten us so off track here, and I promise I'm gonna get us right back on. So my next question that I had for you was, what role does dysautonomia play in GI motility and digestion?
Yeah, so I think we have to break down what how the autonomic nervous system, I guess, what role that plays in our digestive health. And so there's the sympathetic arm of the autonomic nervous system and the parasympathetic arm. And so the parasympathetic arm, the kind of the the old adage is the rest and digest arm, right? So it helps from everything from making sure digestive juices are flowing at the right time to how things coordinate. So from the moment that we swallow our food, it has to be in a very coordinated fashion. It has to be pushed to the bottom of our esophagus. The lower esophageal sphincter has to relax. It enters the stomach, and the stomach is a it has to accommodate. So it doesn't just receive the food and start mashing. It has to accommodate and get bigger, right? And then it starts its process of micturition and churning up food into microscopic particles called chyme, which then it goes into the small intestine. And the small intestine has to move that down to the colon in very coordinated fashion. And we take all of this for granted, right? And then the rectum, goodness, the rectum. Uh, I shouldn't have screamed that. I think there's other people next door. Don't scream rectum outside. Generally, not a recommended thing to do. Yeah, so the rectum is also fascinating, right? And it has to accommodate the stool, and then it has to talk to the brain, saying, "Hey, it's time to go to the bathroom." And the brain has to open the sphincter, and then you defecate. So there are diagnoses that so if any part of this goes wrong,
Mhm.
someone can really struggle, right? So there
Mhm.
are diagnoses of the esophagus when it doesn't empty well. Similarly, when the stomach doesn't accommodate or when the stomach doesn't empty. And so when someone has dysautonomia, it can literally affect any part of their GI tract.
Mhm.
Generally speaking, it slows things down if you have dysautonomia.
Mhm.
And,
Okay.
that could be also due to just food avoidance because food hurts. People with dysautonomia and postural orthostatic tachycardia syndrome, generally speaking, aren't as mobile as they otherwise were before they had the diagnosis because getting up and exercising is really challenging. So that also affects the way your GI system moves and coordinates. You're generally more constipated if you're not up and moving around. But yeah, but not only does it affect the motility, but also the sensory component of things.
Mhm.
So, and I'm sorry, one more part of the motility. So, one of the biggest diagnoses I make is gastroparesis, where the stomach just doesn't empty very well.
Mhm.
And to tie this to the next point, where there's also a sensory element to issues with the autonomic nervous system. So, when someone has gastroparesis, right, the stomach doesn't empty well. But when we give medications to accelerate the pace of the stomach, people generally don't feel a lot better. So one of the
Mhm.
most known medications we give is something called metoclopramide or Reglan, which
Mhm.
tends to have a lot, it can have significant side effects, but if you use it for a couple of weeks at a time, it's generally okay. But it doesn't make people feel a whole heck of a lot better because there's a huge sensory element to gastroparesis as well. The fact that the stomach isn't accommodating well and food is sitting there, um, it causes a lot of pain. And if you just accelerate the rate at which the stomach moves, people people's pain doesn't go away. And guess
Mhm.
what I'm trying to get to is there's an element of visceral hypersensitivity. So people feel everything a lot more. They feel the churning and the gurgling of their intestines when they otherwise wouldn't. So when someone has dysautonomia, not only is it a motility issue, but there's also a sensory element as well.
Mhm.
And when we talk about the sensory element, there are a lot of ways to go about addressing that. But one of the biggest things is stress management, making people are sleeping well, and you know addressing their mental health and offering tools based on who they are and what they want to do. Because the
Mhm.
more stressed you are, the less sleep that you get, you feel everything a lot more. You talk to
Mhm.
someone with these issues and they have a poor night's sleep, they feel everything a lot more. The pain is worse, the cramping is worse. So you have to kind of address all of these issues, not just, hey, we'll give you a medication to help speed things up. And I wish it was
Mhm.
that simple, but it's just not.
I love how you broke down the whole digestive process because you're spot on that we do take it for granted. And when we simplify these GI even just the concepts around digestive issues, we forget about all those different places where things can go wrong and how even just not just medications, but even just like other supplements, dietary supplements, they don't, there's not usually just a band-aid fix. And if it is, how do we make sure that it's personalized and that it's actually addressing what's going on in that whole system that you just mentioned there?
Yeah, exactly. And then you have to take a whole body approach. And so,
Mhm.
as you know, like I wouldn't do anybody any favors if I said, "Oh, we'll start this medication, but let's not touch on diet." So, diet plays a huge role into this. And so, we do know with gastroparesis and delayed gastric emptying, the best kind of approach, and this is painting with a broad brush, this is not for
Mhm.
everybody, is a combination of diet, neuromodulators if people want to, and that changes the way people perceive their intestines. And some people are like, thanks, but no thanks, I'm not into that. All good. And then
Mhm.
sometimes a promotility agent as well to help things move along, whether that's
Mhm.
Reglan or erythromycin. But everybody's different. And I usually start with making sure people we're addressing their mental health, they're sleeping well, and then the diet. And that's where I start. And then we
Mhm.
can layer things on as we go. But I start with the kind of the low hanging fruit, the most effective, least side effect approaches first. And then if we need to, we can kind of go into therapies. And
Mhm.
these therapies, neuromodulators, really affect the way that we sense our intestines, like Cymbalta, amitriptyline, bisipramine, medications like that. They are not forever. We usually use them for like a finite period of time, 12 to 14
Mhm.
months. And then we're usually able to taper off medications. And the pain sometimes kind of gets a lot better, if not goes away altogether, even despite their dysautonomia persisting.
Mhm. Yeah, I tried a lot of the neuromodulators during my journey with my GI issues. And while they were very helpful for the specific, like I do have that visceral hypersensitivity, especially during times of high stress. And I unfortunately didn't like do well with the other side effects. I think just genetically speaking and knowing my family history with medications, it makes sense. But I did really notice an improvement in the visceral hypersensitivity, specifically with amitriptyline. So that was a really, and it was kind of like the way that you're describing the H2 blockers with the, okay, let's at least connect the dots here. It kind of highlighted that, okay, well, so you really haven't been prioritizing the nervous system component of all of this. And you should probably start. And so while it wasn't like, something that I was able to stay on long term just because of my side effects, it was a very important part of my journey. So I think that's, it's important to consider all of these options that your doctor is providing you with. I know I even at the time was very skeptical to try things. And I'm so glad that I did because, I gave it a shot. It taught me a lot about my experience. And I think some of these conventional routes get a bad reputation. And I think that we should not underscore the importance and benefits of them.
Yeah, and it's for the right person, right? Because if
Yes.
someone comes in and
Hmm.
I recommend this, I never push any therapies on everybody. I say, here's a menu.
Hmm.
Let's figure out what works best for you.
Sure.
And when I bring this up, everybody raises an eyebrow, like, I'm not depressed. I'm like, I'm not saying you are. But if even at the end of the conversation, if I describe like how these work, and my general gist is, and I've kind of said this before, I use the example of Cymbalta,
Hmm.
which is a medication that can work for this type of abdominal pain and visceral hypersensitivity. Cymbalta is a serotonin norepinephrine reuptake inhibitor. So it increases the amount of serotonin norepinephrine in our kind of neuronal synapses.
Hmm.
And what norepinephrine is, it's adrenaline. And adrenaline really works for kind of dulling down pain perception. The analogy that I use is, if you're playing sports and you're playing, flag football or and you get hit and you turn your ankle and you have a lot of pain, or you turn your ankle, it's painful, but you can kind of finish the rest of the game because of adrenaline. You want to beat your brother or your buddy or whomever.
Hmm.
And but the next day it really hurts. You got to ice it, you have to wrap it up, etc. And the reason you're able to finish the game is adrenaline. So adrenaline really helps with pain perception. And
Hmm.
so that is, but if I do that whole spiel, that song and dance, I say, look, we're not treating anxiety, we're not treating depression. This is a medication we can really use to help with pain perception. And they're like, I'm not, you can see skepticism on their face. I'm like, we're not using this because you kind of have to believe the medication is going to work.
Right.
If you come into this saying, I'm going to get the side effects, this is not going to work, I'm really not for this, we're not
Hmm.
touching that medication. There's a lot of
Yeah.
other options we can use. It's just one kind of tool in our armamentarium.
Hmm.
And one of the other things I want to talk, and you I mentioned and you pointed this out and very astutely, is the side effects can really affect people, especially those with dysautonomia. So
Hmm.
A lot of these medications can worsen orthostasis.
Hmm.
Cymbalta increases your norepinephrine levels, and we know adrenaline plays a key role in pathophysiology, and we don't want to make that worse. So it's all a balance, and it has to be for the right person. I would never kind of just say we need to put Cymbalta in the water supply or give this out to everybody. It's carefully chosen for people.
Right.
Um, yeah. Oh, one more thing is that hypnosis does work well too.
Okay. Okay.
It
Hypnosis
does.
for, okay.
Yeah. So a lot of this, it's touching into our subconscious,
Hmm.
and a lot of our pain signaling can be subconsciously driven. It's not all there, but a lot
Hmm.
of kind of subject or subconscious factors play a big role into pain perception. So hypnosis is a kind of side effect free tool that we also have as well. It definitely has um, a little bit more. People are skeptical to go down that rabbit hole, and oftentimes we use a lot of other options before we try that. But it is a really neat tool that we have as well. And I don't perform this. I work with kind of GI therapists that help me out with this, but it does
I was
work
just
well
gonna
too.
ask you. Yeah.
Yeah.
The only time I saw it done was like high school prom. Someone got hypnotized on stage, So, I mean, it's so, I mean, when you're at the end of the road here and you're like trying everything, I think that's usually when people come to me when it comes to like the dietary stuff and they're just feeling so frustrated. Hypnosis, they're like, let's do it, let's try it, So unfortunately, it takes people kind of the time to get to the end of the road, but it sounds like a really non-invasive, depending on the way you view hypnosis, non-invasive way to address something that, is very much connected to our digestive tract.
Yeah. And it's all about offering options and describing people's pathophysiology. This is what's
Right.
going on. Here are the
Mhm.
tools we have. Where do you want to go with this? Like, let's work together. Like, it needs to be a partnership.
Well, and
It,
that's, I think, the your approach in your practice is so different just because of that. Like just because you're taking the time to help people understand the pathophysiology of it, most people aren't getting that same level of care. So that's a huge pat on the back to you for actually taking the time for your patients and empowering them also to be able to make those decisions, really.
that means a lot. I do a lot of drawing, and
Mhm.
like, no one's ever chosen to be on a Pictionary team with me because I'm very, very bad artist. But what I've done is I used to use markers on our, we have these kind of, the exam tables that
Mhm.
sit up. And I used to use markers, and then I didn't realize the markers were bleeding through all of the paper sheets, and I've ruined like I think 12 chairs. Where admin was like, "You got to stop this." I didn't realize I was doing that, but that's an aside. I draw a lot of pictures, and I think it makes sense, and I think the patients think it makes sense. But I'll step back. I was like, "Oh man, I'm such a bad drawing." Like, the intestines aren't exactly a really challenging thing to draw, but it's really
I
just
mean,
too bright.
anything can be challenging if you're not an artist. I'm driven by science, and I think that's part of why and understanding like education is always what motivated me to make certain changes and take certain leaps in my own journey. And so I practice that same way where I feel like if you give the client more education, understanding, and science behind it, it empowers them. But it also, once they see it, they're like, okay, this is legit. This isn't just someone telling me what to do. They're telling me the why. They're helping me understand. Like you said, you're walking through them with it versus just like I'm the person telling you what to do. I'm the expert. Just do it. It's a very different outcome just simply by the way that it's being approached and explained.
And I think that you're more motivated to be an active participant in your care when you know why you're doing those things.
Yes, a hundred
I saw
percent.
someone the other day who was a referral for postural orthostatic tachycardia syndrome, and their prior physician was like, "Eat more salt." I was like, "Why are you eating more salt?" "I don't know. Just eat more salt." I was like, "This is why." And so I think if
Yeah.
you understand the why, every time you take a salt tab or add a little more salt to your food or take another like electrolyte supplement, like you realize like, okay, this is increasing my blood volume. The reason
Right.
if I get a little nauseous or dizzy after, like perhaps yesterday, I was playing with my kids or my nephews and nieces, and I stood up and I was getting a little more dizzy than usual. I'm going to eat more salt because that
Hmm.
actually could. So I want you to be able to push the right buttons in your body and know exactly what's going on so you can
Mm.
take control.
Yeah.
You should never rely on a doctor. Like, look, if you need a brain, like you have brain tumor, you need a surgeon, yes, rely on your neurosurgeon. Like that person you need to rely on. But for these chronic issues, this is a partnership. You need agency and active participation. You need to know exactly what you're doing. When
Yeah,
patients are taking notes and come to me with like a notepad, I'm like, game on, let's do
I
this.
love that.
It's
Yeah.
great, right? And so you know that we're in this together.
Yeah, that's amazing. Hypermobility, kind of the same thing. I mean, in terms of, you explained that how obviously the dysautonomia impacts the GI motility. With hypermobility, I mean, a patient described this to me a few weeks ago where she said, like, I have this like lower bloat, but she was saying, I feel like it's because like the muscles surrounding my intestines are almost like lax all the time. And they're not like and she's working on pelvic floor therapy and all that stuff. But how does hypermobility or connective tissue laxity impact the GI tract? And would you say that this is like really a big part for people in terms of their symptoms, or would you say it's not so much?
Yeah, so this is where it gets tricky. So we call EDS or Ehlers-Danlos and MCAS and POTS the dysautonomia trifecta because they
Hmm.
often go hand in hand.
Hmm.
So when someone has digestive issues and they also have EDS, you're like, well, is this the dysautonomia that's driving it? If they do have dysautonomia. So when I talked to someone with EDS, I had someone the other day um, who was like the most flexible person in their class, and they, the skin stretched beyond what it should, and they never kind of put this together. And then they also may have had some POTS symptoms. So when they're talking about your digestive system, you say, okay, is this related to your EDS or is this related to your dysautonomia? Okay, so that's the first thing you have to tease out. So say, for example, we've kind of ruled out the dysautonomia, we're taking care of that. People still have a lot of GI issues. Um, so what does collagen do? So in EDS, right, there's a defect in collagen, which is kind of the scaffolding for our body, our muscles, our joints, our GI system. So when that's lax and not working so well, the muscles that anchor to it can't work as well. So they're predispositioned for slow transit, right? So you want to make sure people are pooping okay.
Hmm.
If you're talking about the patient that you saw, one of the biggest questions I would ask them is, do you feel like you evacuate fully? Because there's a difference between slow transit constipation where things just aren't moving very well
Mm-hmm.
and pelvic floor issues. Okay, so in constipation, stool is too hard, colon isn't moving very well, and pelvic floor issues, it's the pelvis isn't relaxing adequately to allow poop to come out. And I'm sure a pelvic floor physical therapist, like, he's describing this poorly, and please comment below on
It's
how I
okay.
should better
They've already
describe
done their
this.
job on this podcast. They've done a great job, so we won't hold you to
All
it.
right. Yeah, and so one of the key questions I ask is, do you feel like you can't get everything out? And these folks typically have infrequent bowel movements. Their stools are soft, which likely implicate that they don't need a stool softener or a
Hmm.
laxative, because that laxative is only going to make the stool softer, which is what they don't need. But it's
Hmm.
soft, infrequent, and they can't get everything out. And that's when, like, okay, is there pelvic floor issues here? And then there's the garden variety pelvic floor dysfunction. And then there's things that uniquely affect those with Ehlers-Danlos, like visceralptosis, where all the organs kind of sag together and create this kind of congested group of organs in the rectal area, which make it just challenging to evacuate.
Hmm.
That's more of, we work with a pelvic floor physical therapist first, and if we're not making any grounds there, then we pursue visceralptosis. But kind of going back to what issues specifically affect those with Ehlers-Danlos, you have to think a lot about vascular compression disorders. So there's something
Hmm.
called median arcuate ligament syndrome,
Hmm.
which is where the median arcuate ligament is compressing the celiac plexus and celiac artery. And when that happens, you get significant pain in the upper GI tract after eating. What confounds this picture even more is a lot of people have gastroparesis. You're like, is this gastroparesis? Is this something called functional dyspepsia, which is kind of pain overlapped with gastroparesis? Or is this median arcuate ligament syndrome? And it can be really tough to suss out. But again, kind of what we mentioned before is interview is key here. The patients will tell you what is going on, okay?
Hmm.
And key bits of this, of what differentiates median arcuate ligament syndrome from everything else, is, pain tends to get better when they're leaning forward. It gets worse with exercising. There's some weight loss as well that can really happen. That's kind of unique there. I'm sorry, just to back up, the reason why this happens is that kind of the collagen that typically supports these ligaments just is a little bit saggy. And so that ligament can kind of come down and compress the celiac artery, which supplies our stomach. And so when that artery is compressed, it leads to kind of ischemic kind of changes where the stomach just isn't getting sufficient blood flow. That ligament also touches on the celiac plexus, which is the way our stomach is felt and perceived. And that irritation itself can just cause a lot of pain. So
Hmm.
I had this patient the other day who had Ehlers-Danlos, and she was laying on the ground, kind of in not downward dog. I don't know the yoga positions quite well, but she was doing a specific position that she does to kind of free up that ligament to where she feels a lot better. I was like, this is what's going
Mm.
on. There's something called SMA syndrome, which is superior mesenteric artery syndrome, where there's a collapse of your small bowel because of the angle is very acute between your superior mesenteric artery and your aorta, and that kind of collapses your bowel, and that can also have pain after eating. So you just kind of need a provider that understands the complications of EDS and
Mm.
how it can affect your GI system uniquely, so they can look out for these things. I don't look for these things right off the bat because they're quite rare.
Right.
And treating them is tough. Treating MALS is tough. Treating SMA syndrome is tough. And
Mm.
so we do kind of diet first, some medications first, working on, as we talked about, sleep, stress. And if
Mm.
as this is an iterative process, and if we do these things for a few weeks and we're not making any gains, we'll start looking for those zebras. But they're
Mm.
actually just kind of garden variety horses in EDS. It's not really a zebra
Mm.
anymore.
Yeah, you brought up malls. That's something I've been hearing more about in my practice. We could maybe table that for another day, a whole episode on it. Uh,
Yeah. Okay. It's complex, and I could talk on and on and on. There's a couple other vascular kind of
mhm,
compression syndromes that affect the pelvis as well, that can cause
mhm,
constipation, kind of
mhm.
pelvic pain. Pelvic pain is kind of unique too. Like if someone's having pelvic pain, it's probably not uniquely their GI system.
Yeah.
But yeah, so it just takes kind of a careful history and
Mhm.
understanding the various consequences of EDS as it pertains to the gastrointestinal symptom and the surrounding connective tissues.
Hmm. But what's so, I mean, big picture message here is like blood flow, like blood flow being really important. I hear clients will talk a lot about like if they do things like foam rolling or deep tissue massage and they were really tight or something, and that they've noticed that that improves their digestion, or there's specific trigger points that they notice. It just, I think of like the lymphatic system and just blood flow, period, just coming to your digestive tract and how we know that that is crucial. And it's just, it gives you more tools to think about of ways that you can support digestion. But
Yeah,
wonderful.
I learn from the patients all the time because
Yes.
this is more art than science. And
Mhm.
so I will ask patients in clinic, and they're like, aren't I supposed to be asking you questions? Like, no, no, no. And they'll teach me all these things about how they improve their symptoms with kind of, little tips and tricks that I am unaware of, because either the
Mhm.
science doesn't, there's no science to support it, or
Yeah.
it's just something that they figured out on their own. And it's really nice to kind of take these tips and kind of communicate to other people. And I have a running list of like gastroparesis tips to like just help people survive the day-to-day challenges of chronic nausea and getting full early that aren't necessarily medications. And so I learn from the patients all the time.
Yeah. Can you imagine going to the NIH and being like, hey, we want to run a study on how this specific yoga position helps with the, like it's research is wonderful, but there's certain things that you can't replicate. But I love that. That's so wonderful.
Yeah.
All right. So with our time left, I'm trying to think of what is the best use of time. Is there anything that you're really passionate about right now in terms of like what you're seeing in practice? I know you're kind of headed into some future endeavors with your career, anything that we haven't talked about that you think would be really important for the listeners to know?
If you're having issues in your digestive system and you're not pooping well, you got to start pooping.
Hmm.
You're like, I'm bloated, I have pain. If you're not, like, we will always start at, like, this is the mantra that I tell everybody. It's really, really simple. But before you kind of go looking in places or scanning, if you're not pooping well, uh, nothing's going to feel great. And so that's
Yeah.
where we start. And that's easier said than done, right? Like a lot of people have
Mhm.
a really tough time pooping. So, but that's where we always start. So that's kind of my motto for life is we gotta work on reestablishing your relationship with the porcelain throne.
Yeah, I love that. Yeah, I mean, when you yelled the rectum, I laughed, and I tell this story kind of frequently because it's funny. When I was a kid, it was in like grade school, you were given a part of the body to present on and describe its functions. And my sister had the rectum and she was like mortified, absolutely mortified, like came home, was so upset. Then I went to that same class 4 years later. I then got the rectum as well. You literally pick out of a hat. And my mom was dating someone at the time. And I'm like at dinner, we're at Uno's, and I'm like can I practice my presentation in front of you? Like, hello, my name is the rectum. I am the lower part of the I was so proud to be the rectum. Like it describes me in a nutshell because I was so unfiltered and like comfortable talking about bowel movements as a kid because I was always in the bathroom. So
I have so many questions of why would they give an elementary school child the rectum? Like, why would you choose like the spleen or an eyeball? Like, there's so many parts of the body that just aren't the
I
rectum. But hey,
know.
maybe it propelled you to the career that you have right now, and that
Yeah,
was your
this
early
is
starting blocks to being a
2025.
dietitian.
That was, a long time ago, probably 20 something years ago. So the times have changed. Maybe they're
For
still
sure.
doing it, who knows? But hopefully whoever it is that gets the rectum is very proud and, breaking taboos on discussing bowel movements because, it's how we make some changes here.
Creating future gastroenterologists around the world.
Yes.
Yeah. So the other thing that I'm excited to share is, and I don't love plugging myself, but I'm quite excited about it. That you know, I I've been in practice for a couple years, and I've been increasingly frustrated by the care that I can provide in a traditional system.
Mhm.
Um, I love I love the doctors that I work with. I love the group that I'm with, but I don't have enough time. I don't have a therapist and a dietitian, and I'm always behind, and I'm always apologizing for being late because, quite frankly, a lot of the nuances of these conditions, if you want to treat it well, take time to tease through.
Mhm.
So I gave my notice earlier this year, and I'm creating my own clinic called Ever Better Medicine, which is a exclusively telehealth platform clinic where we deal with chronic, invisible, and complex GI conditions, including dysautonomia, POTS, and mast cell activation syndrome. We treat the GI complications of Ehlers-Danlos. We're telehealth, so I can't do the hands-on part of things, nor do I know how to. But I also have a network of really amazing people who treat dysautonomia after working in this space for a while, whether that's physical therapists, surgeons, et cetera, to get you in the right place, depending on what's going on with you. Um, we are going to be in North Carolina and Illinois to start. And it is a cash-based model because, quite frankly, if I try to charge insurance and just talk to people for an hour, we wouldn't survive a month. We
Mhm.
think our prices are quite modest compared to a lot of kind of counterparts out there. And the intention is for us to be kind of rented for 6 months, 12 months, 18 months to get you on the right path and give you a diagnosis and a treatment plan. And then once you sign up with us, you can talk to us in perpetuity on our kind of our telehealth messaging platform. I always want to hear from you. We can always, yeah, kind of push the plan and get you feeling better. And that doesn't have to be in person necessarily. Like if I've met you for 6 months in here, we kind of have a sense of who you are, what your body does, how it works, and we can kind of make tweaks over time via the telehealth portal. And that's kind of what I do right now. I'm so freaking busy. I can't see people for months at a time, but goodness, I'm on the chat every single day with them, making sure that we are moving in the right direction week by week. And
Amazing.
that's the group that we're establishing because we're taking a new approach to healthcare, and it's the way that I think we can really support people with these conditions. And so I'm really
Mhm.
excited to start this endeavor. It starts in June. And if you're interested and this makes sense for you, I'm excited to meet you and work with you.
Awesome. Well, I will be sure to plug that link in the show notes here. And you should absolutely plug as much as you can because we need people like you and your practice. We need this approach. We need the level of care, the level of consideration, knowledge, all of those things. I wish that your practice was around when I was struggling, so don't ever apologize for plugging something that is going to change people's lives in a system that actually works. That's what we need in terms of healthcare. That's what healthcare really means.
No, that means a lot. And starting this social media journey earlier this year has just shown me how many people are struggling out there without answers, who are trying to put together the puzzle themselves. Like, why are they on my Instagram looking
Hmm.
about, hearing about dysautonomia as opposed to kind of perusing pictures of like cats doing silly things? It's because they're desperate to figure out what's going on and why they feel so lousy every day. Because time and time again, people have told them, hey, the tests are normal. Like, it's all good. Like, you don't have Crohn's, you don't have cancer. It's probably stress. Like, try deep breathing. And I hear that every day, and it drives me nuts.
Yeah.
And that narrative is common, I think, because providers don't honestly know, and quite frankly, anxiety can do a lot of these things. But
Sure.
it's anxiety, and it's not anxiety until you prove it's not anything else. It's not the
Hmm.
default. And yeah, I'm glad that the Instagram to some extent has given people answers, and now I'm looking forward to meeting them and connecting the dots further, and then really working with them on an individual level to um, give them control over their health again.
Yeah, that's the most fun part is making that connection. I've had the pleasure of doing that over the years, and yeah, just developing deeper connections with people in the space and getting to follow their journeys and see them get better. I mean, that's right. That's why we do what we do is just make at least one person's life better every day in some way. And just thank you for the work that you're doing. It means so much to the entire field of nutrition, but especially gastroenterology.
That means a lot. Thank you so much.
Yeah. Well, thanks for coming on today. Your Instagram handle, what is it? Oh no, I lost you. Oh, I see you now.
Hey, what
It just
happened there?
it just froze. I don't know.
Yeah. All right.
What is your Instagram handle for people that want to go follow you?
Yeah, it's Dr. Zach Spiritos.
Okay. I'll also put that in the show notes. Thank you so much for your time, for coming on today. This is such a great conversation. Would love to do this again sometime. I know you've got a lot going on in life, but there's so much that we could unpack, and you've given folks so much great information here already today. So thank you for that.
My pleasure. Thanks for having me.
All right. Awesome.